All right, it looks like we're going live now. Fantastic. Welcome into this space, everyone. Hello, welcome. Come into our meeting. Come into this session today. Welcome. Please make yourself comfortable. Well done for getting here and finding the right link at the right time, and you've made it. It's worked. Settle in. We've got a wonderful session for you today. Make sure you have in front of you what you need to stay comfortable for the next couple of hours. And we've popped a little prompt into the chat box for you. If you're new and you haven't joined us live yet for this conference, find your way to the chat box and you'll see a prompt there that says, hello. Make sure you have what you need in front of you to stay comfortable. And if you'd like to say hello and let us know where you're zooming in from, you can pop that into the chat anytime. It's always nice to hear from you. For those of you who have been with us this whole time live through the conference the last few days, welcome back. Thank you for your attendance. And we'll make an official start in a few minutes. So just settling into the space and we'll start pretty promptly on the hour. All the way from Ocean Grove. Nice to see you. Welcome in, everyone, to the space. If you're just joining us now, welcome. Well done for getting here on time. You've got the right link. You're in the right place. Settle in, make yourself comfortable. We've got a couple of hours together. Feel free to say hello in the chat box. We've got a prompt in there. Let us know where you're zooming in from. And we'll be making a start in a few minutes. So just settling into the space for now. Make sure you can find that chat box. We love to have comments and questions flowing in while the presenters are giving their talk. Welcome, welcome. Okay. And we'll be making a start shortly. Just settling into the space. Welcome, everyone. Thank you for being here. We've got a wonderful couple of hours together coming up. If you've just joined us now, hello, welcome. Make sure you can find that chat box. We love to have a flow of chat, comments and questions coming in while our presenters are giving their talk. And feel free to say hello and let us know where you're zooming in from. If this is the first time you're joining live, welcome. And we'll get started soon officially. We're just settling into the space. All right, looks like we've got a few more joining now. Welcome into the space. Make yourself comfortable. We'll be starting very shortly. feel free to have a look in the chat box. Make sure you can find the chat box. We like a bit of activity there, that's for sure. Yeah, we're coming from all over. Welcome, everyone. All right, I'm going to go ahead and make a start. Hello, everyone, and welcome to our Saturday session for the conference. If you haven't joined us live yet, hello, I'm Dr. Bronwyn Lee. I am your host, your conference curator, and the director of the Perinatal Training Centre. Thank you very much for joining us here in this space. Settle in. We have a wonderful session today to round out our program. A reminder to take care of yourself. Do go gently today as we journey together. We know that we'll be talking about some difficult things, particularly if you do identify as neurodivergent yourself or have a loved one who is. So do take care of yourself in whatever ways you need. Take a deep cleansing breath, turn off your camera, close your eyes, put your hand on your heart, whatever it is you need to do, move your body. And if you do find that today is activating, then please do debrief with someone that you trust. It's great to have you all here, and allow me to open this session. By way of reminder, here is our program. And look, we are on session 4. This is our final session for the content portion of our program. Beyond today, we have a break and we will reconvene in 5 weeks for our special bonus session of a Q&A session with the speakers. More on that later, but for now, in this session, we have 2 speakers. We have Amy Pember speaking on infant experiences and Sarah Edwards talking on the therapist experiences. While the presenters are speaking, they won't be able to see any of the chat that those of you who are live might be posting. The presenters will present uninterrupted, and then toward the end of their presentation, once they're finished, there may be some time to share some comments or ask a couple of questions. So if you're joining us live, please use that chat box. We'd love a flow of communication there. Pop in your comments. If a presenter says something that you like, pop it in there. If it raises a question for you, pop it in the chat. And if you like something that someone else has commented on, hit a like on it, and that way we know that you're also interested in that question. All right. First up, we have Amy Pember, who we did hear from yesterday. Amy is an ADHD perinatal psychologist from the beautiful southwest region of Busselton, WA. Her professional focus on perinatal and infant mental health has been deeply shaped by her own lived experience of the transition to motherhood, particularly that significant adjustment from being a working professional to becoming a stay-at-home mum. Understanding this journey through the lens of her neurodivergence has given her unique insight into the experiences of autistic and ADHD parents in the perinatal period. Today, Amy is speaking with us about the baby's experience in the neurodivergent parent-infant dyad. Welcome back, Amy.
Hi, everybody. Just going to take a moment to have a breath and to center myself and warm up using the slides. Okay. There we go. So, welcome and thank you for joining us today on a Saturday and bright and early for those of you in WA. Today we'll be entering a space that is often overlooked in perinatal care, the lived felt experience of the baby, especially when they're being held and shaped within a neurodivergent caregiving relationship. This session is called Held in the Tender Space because the early postpartum is just that, tender. It's a time of intense transformation, of co-regulation and relational becoming. And when a baby is held by a parent who is autistic or ADHD, whether diagnosed, late identified, or unaware, the rhythms of bonding and connection may look different, but they are no less powerful. Together, we'll explore what it means to centre the infant's sensory and relational world without pathologizing difference. We'll also honour the strengths and needs of neurodivergent parents, recognising how their authenticity, advocacy, and attunement shape the baby's earliest experiences of self and safety. This is a presentation about nuance, compassion, and possibility. My hope is that it invites you to see the dyad differently, to hold space for both the baby's vulnerability and the parent's truth. Let's begin. And I'd just like to acknowledge and pay respect to the people of the Noongar Nation on Wadandi Budja here in Busselton, WA, the land on which I present from today. I also acknowledge the traditional custodians and elders of the various lands across our nation from where you are all located. I would like to share my support for all First Nations families to have access to birthing on country. Sovereignty was never ceded. And some of you may have heard me say this yesterday, but it's to me as important as to remind you, but also for those that might be attending today who didn't see me yesterday. So as we all know, stories from the perinatal space can be hard to hear and sometimes hard to hold. And many of us will have our own lived experiences that can become activated. Perinatal work is deeply personal work. So I encourage you to take care of yourself and to listen to your heart, mind, and your body today. If you need to take a break from the content, please do. You will have access to the recording to watch at a later date. And so I'm committed to creating an inclusive and safe space for everyone. I value people of all abilities, bodies, genders, sexualities, cultures, ages, neurotypes, and backgrounds. And this includes all of you. Follow your needs and use your strategies and supports freely. I acknowledge that while I present here as a professional with a disability, I'm also privileged in many other ways, and I aim to use this privilege to give voice to others. Neurodiversity affirming practice does not exist without intersectionality. And again, the legal stuff, not so fun to talk about, and it feels very serious. However, it helps us to all make the terms of use and the copyright explicit. So I have invested a lot of time and money and executive functioning and emotion regulation through the development of my clinical knowledge and skills. This has all led to the development of the presentation that I'm sharing with you today. I'm excited to be sharing this with you today, and I hope you'll find the slides useful for your continued learning and reflections. But please remember that these resources are for your personal use only and should not be shared without written permission. This includes with colleagues within your organisation or otherwise who have not purchased a ticket for the conference. And so, who am I? Well, I want to introduce you to me through the lens of the infant's experience. So, in the top right, here I am as an infant. We now know that I was an ADHD baby. I was described as a difficult sleeper. I co-slept with my parents until I was 3. I cried a lot. These weren't signs of something wrong with me. They were signs of a sensitive, sensory-aware, deeply connected little person asking to be understood in the only ways that she could. So the picture that says first time neurodivergent mother. So here I am again, a first time mum. Still undiagnosed, still interpreting my experience through neurotypical expectations. I was overwhelmed, exhausted, and wondering why bonding didn't feel the way that I thought it should. In the bottom right, yes. No, yes, yes. Here I am as a second time ADHD mum, still unaware of my neurotype, but now with a little more trust, a little more self-trust, and a little more gentleness. It wasn't until my own children were 7 and 9, both beautifully ADHD themselves, that I began to see myself more clearly. My identity came into focus, not just through self-reflection, but through relationship, through seeing myself mirrored in my children and understanding that what once felt like brokenness was actually difference, misattunement, and unmet needs. This journey gives me a deep respect for the unspoken experience of babies, especially neurodivergent babies, and a deep belief in the healing power of being seen. So my sky high objectives, but you'll take bits away today and you won't take it all, and that's okay. I would just like to invite you to start reflecting on your clinical practice from the lens of what it might be like for the infant. Oops, sorry, what did I do? I pressed the... Oh. There we go. Oh, okay. So as we begin, I invite you to hold a particular lens with me, one that centers the baby's lived and felt experience. This isn't about adult interpretations of behavior or checklists of milestones. It's about how it feels in the baby's body to be with their parent. How safety, regulation, and connection are sensed before they're ever named. At the same time, we hold the parent's reality with deep compassion, especially when that parent is navigating the world with a neurodivergent mind and nervous system. We're not here to pathologize difference or to idealize early parenting. We're here to create space for both baby and infant, baby and parent, to be seen, understood, and supported in their full complexity. So in this session, we'll reflect on what it means to foster connection, even when the rhythm of bonding looks different than expected. Because in this tender space between baby and parent, when we make room for both stories, something powerful emerges. Attunement that is flexible, safety that is co-created, and relationships that honour authenticity for all members of the dyad. Just have a sip. So the early postpartum period is often spoken about in terms of the challenges of sleep deprivation, hormonal shifts, identity upheaval. But I want to invite us to view it as that tender space, the profoundly formative window for both baby and parent. It's a time when neurobiology and relationships are being written into the body. For the parent, it's a time of deep identity transformation, when the self is being reshaped to include this new little person. Connection isn't just emotional, it's physiological. The regulation of heartbeat, breathing, and cortisol all happens in response to the tone of the relationship. And for the infant, everything they experience is filtered through relationship. Their nervous system is learning what safety feels like, how it is communicated through presence, touch, voice, and rhythm. This is the foundation of attachment. Not just what a caregiver does, but how it feels to be with them. Not perfect, but responsive. Not performative, but present. And for neurodivergent parents whose sensory systems, energy levels, and relational rhythms may differ from the norm, this space may look different, but it is no less sacred. And when we understand this early period as a co-created and embodied space, we can begin to support it with that greater nuance, compassion, and care. So when we talk about safety for babies, we're not talking about an intellectual concept, something that they can think through or name. Safety for an infant is entirely embodied. They feel it in how they're held, in the rhythm of a caregiver's breath, in the tone of voice, the pacing of movement, and the predictability of presence. Emotional safety is not built from big moments. It's built from micro moments. A glance that meets their gaze, a pause that honours their sensory rhythm, a soothing tone that says, I am with you. Consistency, warmth, and attuned presence are what allows a baby's nervous system to begin organising itself, to settle, and to grow. It's important to remember that being held is about more than arms. It's about being held in mind, held in rhythm, held in a way that says, you don't need to do anything to earn my regulation. I offer it freely. This is co-regulation. It's not a technique, it's a relational state, a shared sensory experience. And it becomes the foundation of what the baby will later call safety, trust, and love. For neurodivergent parents, the ways this co-regulation unfolds might look different, and that's okay. We are here to honour that difference, not correct it, to support it so that the baby's body can still feel held, even if the holding looks unconventional. Sit. So for a baby, there is no me separate from you. Their sense of self, of other people, and of the world emerges in relationship. Before there are words, before there is narrative, there are sensory moments. Moments of eye contact, the sound of a familiar voice, the rhythm of being rocked, and the synchrony of a breath that matches their own. These are not just cute moments, they are building blocks, tiny relational events that shape the baby's nervous system, their emotional map, and their internal sense of, am I safe here? Do I matter? This is why micro moments matter. They don't need to be perfect, and they don't need to be constant. What matters is the repetition, the repair, and the presence behind the gaze or the tone. In these moments, secure attachment begins to take root, and so does the early capacity for self-regulation. Not because the baby regulates on their own, but because they are first regulated with and through another. For neurodivergent parents, these relational cues may unfold differently, perhaps with less eye contact or more rhythmic touch or different vocal patterns. But that does not make the relationship less meaningful. When we widen our lens, we can see that relational attunement comes in many forms, and the baby's body knows when it's real. Oh, I've done it again. My keyboard is too close to my hands. Let's go backwards. Get to see sneak peeks of the photos. There we go. All right. When we think about the needs of infants, there's often an assumption of universality. Certain milestones, certain cues, a predictable way they seek closeness or calm. But neurodivergent infants may experience and express their needs differently right from the beginning. For example, a neurodivergent baby might have heightened or lowered sensory thresholds, meaning that touch, sound, or movement might either soothe or overwhelm them far more quickly than we would expect. They might have different rhythms, sleeping or feeding patterns that feel unpredictable, or ways of self-regulating that don't fit typical developmental models. Some may show less overt seeking of connection, not because attachment is not forming, but because the way they process proximity, voice, or facial cues is different. Others might seek connection intensely, but need it to be delivered in very specific, structured, or sensory safe ways. Importantly, if these needs are not recognised early, the baby may experience chronic stress or misattunement. Not because anyone is doing something wrong, but because their cues are misunderstood or overlooked. This is where early affirming support makes a huge difference. Not just to help the baby regulate, but to support the parent in understanding what their baby is asking for, how to meet the need in a way that works for both of them. When we widen our understanding of infant needs, we open up new possibilities for connection, rooted in responsiveness, not sameness. So when we think of attunement in early caregiving, we're often drawing from neurotypical models: mutual gaze, sing-song voice, animated facial expressions. What happens when a parent's natural way of relating does not fit those norms? Autistic and ADHD parents may express connection in beautifully different ways. For example, through sensory synchrony, rocking in rhythm, breathing together, through body proximity, being close without needing to speak, through repetition, the comfort of sameness, of ritual, through shared silence, a quiet presence that says, I am with you, through intense focus, a deep dive into the baby's cues, held with full attention. These are not deficits. They are valid and valuable ways of offering connection, especially for babies who may also be neurodivergent. In fact, these relational styles may feel more regulating and more attuned for some infants than the traditional markers of bonding that we are taught to expect. Our role as clinicians is not to pathologize difference, but to recognize its relational integrity, to see the intention, the connection, the love that may be expressed differently, but no less deeply. This is how we begin to create space for neurodivergent rhythms of care to be not just accepted, but honoured. Much of what we understand as good or secure attachment is based on neurotypical norms. We're taught to look for things like frequent eye contact, turn-taking in vocalization, and playful facial mirroring. And yes, these can be meaningful markers of connection, but they are not the only way that connection looks. For neurodivergent parents, especially those who are autistic or ADHD, attunement may not show up in these expected ways. There may be less direct eye contact. I just wanted to point out this photo. A lot of the eye contact that I made, this is my first child, Imogen, a lot of the eye contact I made with her was actually through selfies. And this is a child that has grown up who does not like eye contact. And so I remember her not liking holding eye contact as an infant as well. Nobody told us to do this. This was just something that I found would draw that connection between us more easily. So there might be long pauses before we respond. Play might look repetitive or sensory focused or solitary, but it's still deeply engaging. These expressions can still carry presence. They can still say, I see you, I feel you, I'm with you. When we rely too heavily on conventional measures, we risk misinterpreting these moments as disconnection, when in fact they may reflect profound attunement through a different sensory or communicative channel. This is why it's so important that we widen our lens. Neurodivergent caregiving is not less. It's just not always visible through the tools that we are used to using. When we look more closely with curiosity and compassion, we begin to see the strengths, the nuances, and the deep potential for secure, meaningful attachment. Secure attachment does not have to look typical. It has to feel safe, consistent, responsive to both baby and parent. So even the most loving and well-intentioned parent can struggle to stay regulated, especially when they're navigating sensory overwhelm, executive functioning challenges, or autistic burnout. For neurodivergent parents, these experiences are not rare. They are often part of daily life, especially in the demanding and unstructured early postpartum period. When a parent's capacity for co-regulation is reduced, the baby feels it. It's not because the parent does not care. It's because the relational cues shift. The voice tone may flatten. Responsiveness may be slow, or the sensory environment may feel overstimulating or chaotic. Infants sense this through changes in rhythm. They may become unsettled, cry more, turn away, or go quiet. But here's the key. Rupture is not a failure. Rupture happens in every relationship, including the healthiest ones. What matters most is the repair. When a parent comes back into connection, whether it's through a touch, a tone, or a quiet presence, the baby begins to learn that relationships can be flexible, that disconnection is not the end of the story. This process of rupture and repair can build resilience. It teaches the baby, I can come undone and I will be gathered again. For neurodivergent parents, we can support this by helping them name what is happening, by reducing shame, and by scaffolding moments of reconnection that feel authentic and accessible. In doing so, we help both baby and parent build trust, not in perfection, but in the strength of returning. So in this space, we are holding two stories at once. The baby brings vulnerability, but also sensitivity, receptivity, and a developing wisdom of their own. The parent brings their own needs, capacities, and a lifetime of experience, including sometimes a history of being misunderstood. When we work with neurodivergent parent-infant dyads, it's easy to focus on what seems to be missing, on what's hard or delayed or out of sync. But what if we first asked, what's working? What's already present? What strengths are already showing up in this relationship, even if they don't look typical? Affirming both members of the dyad means holding complexity with compassion. It means resisting reductionistic narratives of risk or of deficit, and instead recognizing the richness of difference. We can do this through our clinical formulations by naming the story naming the sensory attunement, we observe the rhythmic rituals that soothe or the quiet presence that calms. By shifting our gaze, we make the invisible visible. And from that place of affirmation, then we can gently scaffold, not to fix what is broken, but to support what is becoming. This is the heart of neurodiversity affirming, infant-centered work. To create room for both baby and parent to feel safe, seen, and supported together. So how do we support these neurodivergent parent-infant relationships in ways that are truly affirming? We begin by creating the conditions in which connection can unfold, not forced, not rushed, but gently supported. Pacing is key. Many neurodivergent parents need more time to process, respond, or regulate between caregiving demands. Slowing things down allows room for attunement to emerge. Predictability matters too. Structure, routine, and clear transitions help reduce cognitive and sensory load for both parent and the baby. The more consistent the rhythm, the safer the relationship feels. Sensory support can be a game changer. That might mean reducing visual or auditory stimuli, adjusting lighting, offering movement breaks, or validating the need for quieter forms of connection. As clinicians, we are not outside of this process, we are in it. Your presence can be a regulating force just by being calm, steady, and attuned. Sometimes our job is to hold the rhythm long enough for the dyad to find their own. Most importantly, we're not trying to change how bonding happens. We're simply creating a space for it to unfold safely in its own rhythm. This is scaffolding, gentle support, flexible boundaries, and just enough structure to hold, but never to constrain. It is about making the invisible visible and honouring the slow, sacred process of connection as it emerges moment by moment. Many neurodivergent parents, especially those who are late identified or still unaware of their neurotype, show up to parenting with a quiet or sometimes fierce resolve. This will be different. My baby will not grow up feeling the way that I did. I will protect their joy, their sensitivity, and their rhythm. Even without diagnostic language, these parents are often acutely aware of what did not feel safe in their own childhoods. They are determined to do things differently. They may be the first in their family to question punitive discipline, to honour sensory needs, or to follow their child's lead in play or communication. They are often fierce advocates for their baby's nervous system and their baby's authenticity, sometimes long before they recognise the neurodivergence in themselves. And while they are doing this, they are often simultaneously reparenting themselves, healing, unlearning, and grieving. This is not always visible. It can look like inconsistency or struggle, but beneath it is a deep intention, a yearning for intergenerational repair. As clinicians, when we attune to this motivation and hold space for both the baby's becoming and the parent's becoming, we offer something powerful: permission to parent with difference, permission to heal while holding another, and trust that change is already unfolding. When we support a neurodivergent parent to feel safe and understood and affirmed in their parenting, the impact does not stop with them. It ripples outward, right into the baby's body. Because babies are exquisitely sensitive to the emotional tone of their environment. When a parent feels more regulated, less judged, more resourced, they are more available for connection, even in the smallest moments. This does not mean the parent is never overwhelmed or uncertain, but it does mean their nervous system is supported enough to offer co-regulation, to show up with presence rather than pressure. And from the baby's perspective, this changes everything. They experience a world that feels safer, a world where their cues are noticed, where they don't have to fight to be understood, where connection does not require conformity. When a parent is gently healing, questioning inherited norms, and creating new ways of relating, the baby absorbs that. It becomes their template for relationship, their sense of safety, their first felt experience of belonging. This is what intergenerational healing looks like in real time, not as a big moment, but as thousands of micro moments that tell the baby, you are safe here. You don't need to change who you are to be loved. So before we close, I'd like to offer a moment of quiet reflection. We've spent this session exploring what it means to centre the baby's felt experience, especially within the context of neurodivergent caregiving. We've looked at difference not as deficit, but as a doorway to deeper attunement, and at connection as something that can look many different ways and still be deeply secure. So I invite you to pause here and to hold these questions gently. What might this shift in perspective invite in your clinical work, in your formulations, in how you hold space for difference? How can we speak about the dyad in affirming ways? Can we begin to describe these relationships with language that honours what's present, not just what's missing? What support might each person in the dyad need? The baby and the parent. They both bring needs and they both bring wisdom. What would it mean to support both side by side? And finally, what neurodiversity affirming language can we adopt to tell this story more truthfully? To reframe what has been pathologized, to make room for strength, for adaptation, and for love, spoken and unspoken. Let these questions linger. They're not here to be answered right away. They are a seed to new ways of seeing, sensing, and supporting. So, as we come to the end of this session, I want to bring us back to the heart of what we've explored. In the tender space between parent and infant, so full of vulnerability, so full of becoming, both can flourish. Not because everything goes to plan, and not because connection looks a certain way, but because when we hold space with understanding, safety grows. Connection does not need to be neurotypical to be true. It does not need to follow the rules of textbook attachment or developmental checklists. It just needs to be felt, safe, responsive, real. Thank you for holding this space with me today, for your heart, your curiosity, and your care. The way we see these relationships, the language we use, the stories we tell, it matters. Because when we change the story, we change what becomes possible for those we support. Let's keep holding that story differently together. Just a little sharing of what has contributed to these ideas that I present with you today. And you'll see quite an integration of lots of different, philosophies, thoughts, mentors. But this is what brings the heart to what I'm saying to you. Cringy final stay in touch slide. Thanks.
Amy, thank you. Take a breath. Move your body. Deep cleansing breath. And a sincere thank you for that heartfelt presentation. It really is so important for us to consider the baby's experience. Thank you for bringing this relational lens from the infant's point of view. Some beautiful comments coming through while you were speaking. Allow me to share a couple of them. And folks, given your live, if you have any questions for Amy, now is the time to pop them in the chat. Amy, one of the things that hit home is that idea of looking for the intention for connection within the dyad and how important that is. Another comment, Amy, this is absolutely divine. I am so enjoying this. I also love seeing your beautiful family photos. And another beautiful comment, I'm going to bottle up my feelings listening to you speak, Amy, and your beautiful wisdoms, and metaphorically put it in my pocket to take with me wherever I go with my children. Are you getting teary on that one right there? I know. And another one, this is hitting home, Amy. You're describing my exact experience. So thank you for taking us into that space and articulating some of the experiences perhaps that the audience has had, that we have had, and speaking on behalf of neurodivergent babies and neurodivergent dyads. I wonder, I know you will be feeling, I don't know.
Okay.
I don't know how you're feeling. I'm sure you're fine, but I know it's a lot to deliver a presentation. And so I'm going to send a question your way. And even if you're clunking over your words, we know that we can get weary after giving a presentation. I'm still interested in your thoughts, Amy. If you can talk to perhaps what you think are the behavioural descriptions or observable differences we might see in an autistic newborn. How do
Sure.
they look different to a typical newborn?
And I'm okay. This is just the overwhelm of it all. Okay,
Yeah.
so
Well, we can't see everyone else, and maybe there are other weeping eyes as well. I'm sure there are some hands on heart, so it's all good. Yeah.
So I think firstly, I just want to say that although autism is not typically diagnosed in the newborn period,
Mm.
I think it is observable if you know what you're looking for.
Mm-hmm.
And it is those differences, there are patterns, like those kinds of descriptors that I shared about how I was described as an infant.
Mm-hmm.
I think that in hindsight, that a lot of parents look back on their later diagnosed child and say that's
Yeah.
what they were like. But I want to kind of make reference to Associate Professor Josephine. I never know how to say her surname. I think it's Barbaro.
Mm-hmm.
So
Yes.
she's here in Australia. She's developed the Social Attention and Communication Surveillance tool, SACS, SACS,
Mm-hmm.
which is actually, I believe, used by child health nurses in Victoria for all of we call them purple book checks here. I'm not sure whether they're purple books for you guys, but so Josie's done groundbreaking research, right? And has identified early behavioural markers of autism in children from as young as 12 months, with some features observable earlier. So according to her research, autistic infants may show early differences such as reduced frequency of eye contact or gaze shifting in response to faces, less consistent response to their name, fewer instances of social smiling, which is that, like, I guess the responsiveness. So when you smile and I smile in return, that doesn't mean they don't smile, right? Differences in vocalizations or less use of gestures. So they might not point or wave, for example. And the differences in sensory input. So that's the heightened sensitivity or like reduced responsiveness to sensory stuff. The thing that I'll give an example for here is I know infant sleep is always a hot topic, and people say things like, oh, you just need to take them to the party and then they get used to sleeping in noise, and you should leave the blinds open so they get to know the difference between night and day. As an adult, I still need complete silence and darkness to be able to sleep. And one of my children needs that, and the other child needs to have just the right amount of light in the room or just the right amount of noise. This doesn't fit with any of the advice that we're given about infant sleep. But if we actually start to focus on how our baby is responding to different sensory environments, like where they sleep best, we follow that instead of the advice, our baby might sleep better, you know. And differences in movement patterns or muscle tone. Again, one of my children is like, and always was, like the rock. Just like when she'd sit next to me for a cuddle as a toddler, she wouldn't hold her body weight and lean in. She would like fully drop her weight onto me, like a dead weight, which would hurt my back. And so that would make me not want to have her hugging me in that way, right?
Mhm.
The other child will more like hold her body weight in the cuddle. Those kinds of differences are, again, it's not that alone is suggesting
Mhm.
neurodivergent difference, right?
Mhm.
But it's the collation of all of these things.
Yeah, you're looking for
And
patterns, more than one thing. If there are a number of markers, it's just enough to bring the curious wondering to mind, huh? And
yeah,
also looking at the
yeah,
parent as well, right?
yes, definitely. But I think I commonly have clients where I am sure that their toddler is an ADHDer, for example,
Hmm.
and I've encouraged them to talk to the child health nurse, and the child health nurse has said, "Oh, they're too young. It's behavioural. It's developmentally appropriate."
Hmm. Hmm.
Now, I know that how we show up in different contexts can change, but I consistently see that toddler behaving the same way, and it is completely different to any other toddler that comes in, right?
Hmm.
Um, Making that family wait until the child is 6
Hmm.
is too late, because by the time the child is 10, what is it? They've heard 10,000 negative
Uh-huh.
um, criticisms and stuff. So,
Yes.
yeah, that's
Thank you for answering that question, Amy. That's it gives us some guidance. And while you were speaking, Sarah Harrower kindly popped in some references into the chat. Thank you, Sarah.
thanks, Sarah.
And a final comment, your passion and compassion are so evident, just beautiful, Amy. Thank you. Please do rest now while we move to our next speaker. Audience, stick with me. We're shifting gears here now. Thank you again, Amy. And we're moving to our second speaker in this session. And allow me to introduce or reintroduce Sarah Edwards. Sarah is a clinical and educational and developmental psychologist who works in her solo private practice, Keeping Mum Psychology. Sarah will share a bit more about herself shortly, and in this presentation, Sarah speaks to us about the professional mask. Welcome back, Sarah.
Thank you very much, Ron. I'll just see. I'm just waiting for my slide to click over.
Of course.
While that's working away, I'm just going to go a little bit rogue just for a minute, Bron.
Yes, go ahead. I welcome it.
And I would really like to take a moment to express sincere gratitude to you for creating this conference. I'm starting to feel myself get upset. Sorry. Years before the rest of us saw its form, you held it tenderly, fiercely, gestating it in mind. This year, conception took place, an act of courage, followed by a pregnancy, months of careful planning, nurturance, anxiety, and anticipation. And over the last few days, it was birthed. From all of us who have learned, connected, and grew, thank you. We are so deeply grateful to be part of its first breath. I also thank you on behalf of all of the neurodivergent families we are all working with or yet to meet. And just like childbirth, as soon as it's over, someone will inevitably ask you, so when's the next one? So that was really important for me to share.
Sarah, thank you. I won't speak to it, but I appreciate it. Thank you.
And a little note to my fellow presenters, you've brought your stories, your science, and your whole hearts. You showed up not just as experts, but as humans, with passion, lived experience, and generosity. Thank you for your time, your truth, and your compassion. I'm honoured to be in your company. Thank you. Thank you for holding that moment for me, everybody, and sorry to get teary before I get started, but it really speaks to how activating this work is for so many of us who are working in this space. Before I get started, I would love to acknowledge the Turrbal and Yugara peoples as the original custodians of the lands of Meanjin in Brisbane. I'm so incredibly fortunate to live, practice, and present from these lands. I pay respects to elders past, present, and emerging. We've already had a really beautiful session this morning from Amy, thank you. And I'm going to be talking about the professional mask, so working as a neurodivergent clinician and working alongside neurodivergent families. A little bit about me before I start. For those of you who weren't able to attend yesterday, Bron has already introduced me as a psychologist, and I work in solo practice in Brisbane. My practice involves working primarily with mothers, while also embracing family inclusive practice, hence the discussion about dads yesterday. The majority of my load is neurodivergent, and typically there is multidisciplinary involvement, including psychiatry. I'm really thrilled to have lots of wonderful practitioners in Brisbane who are really able to support the work that I do with mothers. Just a little note on disclosure before we get started as well. I won't be covering disclosure as part of this discussion because this is just so nuanced depending on profession and professional bodies and codes, and also about personal values. So I really encourage people to seek out supervision or reflection for that topic alone. So I guess, how did I end up here? I think this is always the curious part of the story. How did I end up working in this particular field and with these particular populations? I think I have my own lived experiences of perinatal mood disorder, and over time I eventually decided that I would really love to go back and study psychology. I resisted the idea of becoming a stereotype, seeking to support mothers in the same area that I had a struggle with, but here I am, and I couldn't be happier with the work that I get to do. Working particularly with neurodivergent mothers, I really fell into this work because I was working with probably pointy-end mothers who were really psychiatrically unwell. I had this profound clinical experience of a mother who had been admitted multiple times to a mother-baby unit and came to me in session once having tried stimulants, and the profound difference in her presentation was just so remarkable that I thought, oh my God, what am I missing? What are we missing here? Naturally, the boom-bust cycle, as we may know, meant that the stimulants was not the only part of the story, but it was the beginning, and it was a real place to look and evaluate and consider that maybe there's something more that we need to be thinking about in our perinatal work. I was also incredibly privileged and fortuitous to work alongside Rebecca Gannon, who is no doubt well known in the neurodivergent community. I was having so many lovely hallway conversations going like, what am I seeing here? What do you imagine? And who was able to reflect on her experiences or her reflections of working with neurodivergent families. I was learning about neurodivergence in real time. And I was, sort of collecting data from the patient sitting across from me, thinking this is something that I haven't seen or haven't heard about in any of my training. Over time, I gradually started conducting ADHD assessments with clients, and really pattern recognition took hold with my love of data and hearing the stories of my patients, also part of my story. I thought, hang on a minute, maybe there's more about this for me. As we've sort of been, witness to, there is this beautiful uprising of diagnosis of autism and ADHD in our communities. And I think the thing that has been really outstanding to me is I have patients who are health professionals, I have colleagues who are health professionals, and there was a high rate of diagnosis amongst all of these individuals. And when I started to reflect on my own experiences and theirs, I thought that actually there's so many things about this neurotype or these neurotypes that might actually work as a clinical advantage. I thought about the heightened sensitivity that Amy has so beautifully demonstrated coming into the world as a neurodivergent individual. You may have been called too sensitive for a very long time, but actually it is a profound gift in many ways when you're able to use that skill clinically. Differences in focus and hyperfocus and areas of passion. I think, particularly when I think about psychologists in this field, there are deeply passionate and wonderful psychologists, and I can see how this work often doesn't feel like work. I think feeling stimulated by novel and interesting clinical puzzles. I think trying to get to the bottom and figure out what's going on, and really curious minds. I like to sort of refer to myself as nosy, but I think it's often better to consider myself as inquisitive. I think differences in ability to take on so many interesting projects. I think of the patients that I see and the colleagues that I work with. These are the sorts of individuals, or how are they doing so many different things at so many different times? But the task switching is really remarkable. Conscientious work ethic in areas of interest, the pursuit of knowledge in particular areas that they love, attention to detail and pattern recognition, and a conscientious work ethic. All of these skills, but also recognizing that this is what everybody sees on the outside, what is also happening behind this, but also is this kind of pattern that I'm noticing in my health professional colleagues and patients, is there really data on this? And is this something that needs to be studied? There's already some beautiful research, particularly around doctors who are autistic. I'll mention some studies about doctors, and I think there's one about nurses, but there's none about psychologists as of yet. So I think the first one that I'll think about is that from 2023, holding in mind that these are all recent studies because we're all just recently understanding, these presentations of neurodivergence. I think the mean age of diagnosis being 36 is very interesting. 82% of these autistic doctors were working as doctors. Most common specialties are GP, psychiatry and anaesthetics, which I think, is also something that I have seen in practice. And I think really the most outstanding feature is that mental health was poor, with high rates of suicidal ideation, self-harm and prior suicide attempts. So I think these doctors may be functioning and working in their interest areas, but really what is happening behind the professional front, that this high rates of suicidal ideation are occurring. I think the other interesting part about this study too was that they sort of were able to look under the hood of these doctors, and actually viewing autism as a disorder was associated with prior suicide attempts and a preference for first-person language. So I think also thinking about autism as a brain type is also really protective for our communities as well. I think probably like the perinatal period where there's periods of vulnerability, I think in this study we also found that doctors often reach diagnosis following difficulties in stressful clinical environments or highly demanding career paths, and where there's really inconsistent support from employers and training programs. I think again in terms of the rates of the presentations of the self-harm and the poor mental health, this is also really consistent with a study that demonstrates that there's a higher prevalence for autism in psychiatric outpatient settings. So our doctors are, very bright, but they're also, working really, really hard. One of my favourite studies is in 2024, and it was a beautiful qualitative study who looked at 8 psychiatrists in the UK. One psychiatrist was diagnosed in childhood, 2 in adulthood, and 5 were self-identified. They identified that their lack of recognition was about the lack of autism training, deficit-based diagnostic criteria, and their stereotypical views of autism. I think they noticed, and probably as Amy shared, and probably like a lot of us have experienced, their diagnosis became because of their child's diagnosis. And also importantly, which I think is a really incredible reflection point, lack of self-recognition may also impede diagnostic accuracy with autistic patients. So sometimes being able to recognise our own neurotype can actually improve our accuracy in working with patients. I think the thing that I have shared, and I've shared this actually as I was preparing my talk, I've shared this comment with patients of mine, because the only psychiatrist that had a childhood diagnosis of autism, she really reflected, or the researcher really reflected, that Lisa displayed a deeply positive self-identity and self-assurance that set her apart from the other participants. She was aware of somewhat unique position among her neurodivergent colleagues as she observed the struggles of the late identified adults. And I think in terms of earlier diagnosis and recognition, I think that can have a really profound difference on the identity of individuals. She commented on this: "I'm the only person that actually had a childhood diagnosis. And, you know, they all have this, I don't know, internalized ableism or whatever, growing up and having no clue why everything is a struggle." And I think this is a really powerful anecdote, and it really mirrors what I'm seeing in my patients and my colleagues. There was also a qualitative study with autistic and ADHD nurses, and, you know, I think, you know, recognising that they have their own unique skills and ways of contributing to the nursing profession, but often the work conditions and the managerial support really prevented them from succeeding in ways. Interestingly, having one of my patients who is a health professional returning back to a medical setting with shift work and competing schedules and all of those sort of things, I think sometimes being able to get adjustments and accommodations for the differences can make a really profound difference to some of these individuals. I think, you know, these are really interesting studies too. So looking at ADHD health professionals, there was, again, in the UK, they're sort of leading the way with ADHD diagnosis. They had nearly 3,000 doctors who sought mental health care through the NHS, and over 1/3 of doctors screened positive for ADHD using an ASRS, which is a screening tool. I think the other interesting thing, which I probably should have underlined, highlighted, and italicised, is that the male to female ratio for screening was actually, you know, is pretty much 1-for-1. I think the other thing that was noted in the study too, that there's co-occurring anxiety and depression too, which again makes sense in the context here. So actually this is sort of indicating that actually ADHD might be more over-identified in these populations, which is certainly what is coming clear to me in clinical settings. Again, and so I think there's been quite a few studies of medical students. They're probably great research participants of medical students. And this one was in Saudi. And again, 26% exhibited symptoms of consistent with adult ADHD. And so when we think about our 5 to 10% prevalence rate globally, that is really overrepresentative. I think also it's interesting that, you know, these ones that screened positive were young, they weren't married, and were associated with higher rate of ADHD symptoms. But also I think the other really important thing too is that there was no significant difference between GPA and having adult ADHD. So actually ADHD doesn't always mean that you will struggle or that you're not competent, but actually you still may be able to achieve at the same rate as your peers. I won't read, hopefully I can go back. Just go back. Oh, there we go. Sorry, everybody. There's this really beautiful, beautiful study. I've put the reference at the bottom of this page that really speaks about Lucy, who is a junior doctor, and sort of walks through this case study of Lucy, who is ADHD, and how she gets through her medical training. I've just kind of included a bit of a screenshot here. But when, you know, this example, I won't read it, but talks about how Lucy prepared last minute for her surgical interview. It was multiple stations. It was, really difficult to do really well. And then sort of the internalized shame around not doing well when she had medical parents, et cetera, et cetera. So this steps through what can go really poorly for unsupported neurodivergent individuals, and then it sort of walks through the corrective experiences of being able to well support and scaffold Lucy so that she's able to do a beautiful job as being a surgeon that is supported. So I think in terms of the studies in Australia, they do not yet exist, but there is some acknowledgement in the professional bodies that understanding neurodiversity is really incredibly important. So the Journal for GPs, the APS, but also importantly for psychologists amongst us, there is a competency now that we need to understand neurodiversity and for it to be strengths-based, trauma-informed, which is pretty exciting for those of us working with neurodivergent populations. So I think at this point, it's incredibly important for me to highlight that it is possible to be an autistic and or ADHD and also to be an excellent clinician as well. And I think we need to hold that in mind. I think it's also really essential to call on the lived experience nature of the lived experience workforce. Von Hippel, who is a studier based in Brisbane, really looked at what is it like to live, what is it like for clinicians with lived experience? And they surveyed 180 health workers in a non-government organisation. And they found that if they had really tricky clients or tricky patients, that actually those without lived experience are more likely to experience burnout. And so that actually lived experience potentially provides a buffer. They sort of hypothesise that, passion about their work or maybe, potentially a special interest might be able to sort of facilitate managing those experiences, but also having the lived experience of recognising that sometimes things take a while to improve. So I think there's a real value and there's a real beauty to bringing lived experience to this workforce as well. Really anecdotally, in work with patients and colleagues, I think burnout occurs not so much from the work itself, but from workplaces that are non-affirming and not psychologically safe. I think the demands of life outside of health professionals exceeding capacity. I think a lot of lived experience clinicians are also parenting neurodivergent children, which may be also experiencing their own systemic difficulties with systems that aren't designed for them. And I think as sort of the qualitative study indicated a little bit earlier, there's often loads of internalised ableism. And when I say that, I mean, I should be able to cope with all of these things at the same time, and I should be able to manage, and why can't I? Because I might be bad or broken. So interestingly, I find it's not particularly the work that really burns people out. It seems to be a lot of the circumstances outside of work. So I think when I think about the neurodivergent identification experience, I think the other tricky part, and probably like the perinatal professionals amongst us who might be navigating, supporting early parents while also being early parents themselves, I think there can be a parallel journey between, potentially recognising that you might have neurodivergent traits while also exploring this alongside your patients. And this can be quite a interesting and really difficult experience. So it might be, you might be feeling all of the feels in parallel with your clients, or just sort of have a quiet wondering going on in your mind. So to take from the qualitative study, I think, there were some beautiful quotes which really sort of highlighted a lot of what I hear clinically. And I think that a lot of neurodivergent clinicians recognise traits in their own children or through their patients or work. Example by these quotes, all sorts of little things that I read up were ringing bells, and I was seeing that I had sort of milder versions of what I was seeing in my son. Another psychiatrist said, I very much enjoyed my CAMS placement, and I really felt most at home with the 7-year-old autistic and ADHD children. I thought, these are my people. So it might be a really interesting experience to be recognising parts of you in the work that you are doing, but also through your own children. People may start to mention things or may start to query. I think no one is better at diagnosing a neurodivergent person than someone that has been recently diagnosed themselves. So I think about, again, these comments. I make a bit of a joke of it at times, actually, because I think it's an open secret among some of my colleagues and indeed some of my patients that I'm probably autistic. I think this was sort of a powerful reflection, which I'll talk a little bit more about. But Paula, her pseudonym, said she sort of questioned a friend, a clinical psychologist who had known her quite closely through the trajectory of her whole career, classmates through primary school all the way through university. Do you think there's any chance that I could be a total hypochondriac here. Could I have like the girls' version of autism? Paula was stunned and felt somewhat humiliated by her friend's reply. She went, "How's that taken you so long to realise?" And I thought you already, I was like, well, no, I didn't. And so I think this is also something that I hear too from professionals that potentially have been working in mental health or perinatal services for a really long time, finding it really difficult, or feeling that they are humiliated that potentially people have known something about them for a lot longer than they have known that about themselves. I think something that also arises is really conflicting feelings around this diagnosis, particularly for late identified folks, as sort of mentioned by Paula's study a little bit earlier. Again, Paula sort of said, when she said that, I felt a bit, gosh, so she's known this behind my back and not said anything. And then I felt a bit humiliated. Maybe other people would know. I felt a bit thick being a psychiatrist who's had 7 years of therapy, who would diagnose and recognize autism in other people. For me not to realize that until 40 was a bit like, well, that's a bit ridiculous. And I hear this narrative all of the time. It really, it really sort of destabilizes one's sense of self. Another psychiatrist said it took me about 3 months to get comfortable with the idea that maybe I did have autism. The tension between recognizing yourself as autistic and the idea of autism as a disorder is still something that clinicians are having to reconcile. And Alistair pondered, how do you set your stance of normal? I think this is something I commonly see too. What is normal? Do neurotypical people exist? This is kind of the things that I get asked in session very regularly. I think the people that are assessing neurodivergent folks in our field, I think one of the psychiatrists reflected that his own lack of self-awareness made it difficult to recognise autism in his patients. He sort of thought, well, the houseman, well, he was so much like me, so this is kind of like a wardie. He was so much like me. So how could, we both sort of be autistic? That's a bit, interesting to think about. And then Paula, again, our beautiful one that was told, sort of felt a little bit humiliated. I've never heard of masking before, but they were talking about women masking and doing things like inventing social rules to survive social situations. I thought, well, that's normal. I would do that. That's just being clever, isn't it? Being clever and strategic. Why is that autistic? In one of my lectures recently, I had a beautiful intern sort of put their hand up and, want to understand masking. And there was some lived experience in the room who demonstrated, or were able to articulate experiences of masking. And this beautiful intern said, well, doesn't everybody do that? Internally, I tick things in my mind. I think also in parallel, a lot of health professionals really feel the risk of dismissal, much like our patients do in parallel. I think just to sort of read this quote as a start. So if we're saying that when we see a patient, well, I do that, even if we're saying in our heads, we're saying that because we're not autistic, well, actually, we don't even know that we're not autistic. And a lot of us have turned out to be autistic. So if we don't recognise ourselves, how on earth can we diagnose the patients accurately? So I think this is really important about the reflection. But I can tell you that a lot of the late diagnosed people that I'm working with are also concerned. What if I'm just really good at convincing the psychiatrist that I have ADHD? What if you know, what if I'm kind of pretending or I'm masking or it's not really true? And then even post-diagnosis, 2 years down the track, right? Like, you know, I'm still not sure entirely if it's true. How could it be something that is this, you know, simple, I'll put in inverted commas, that could have explained so much of my own experiences, you know, for all of my life? How could this have been something that was not picked up much earlier? So I think our patients will share that they're scared of being assessed or have anxiety around being assessed, but I think this is also common for health professionals too. So I think for our folks that are already identified, I think really recognizing that you already have so much value and that looking after yourself is absolutely key. I think what helps for individuals, there's a study that sort of identifies this, is really understand your own presentation, your own sensory needs, and to borrow Amy's term, you know, be able to recognize your own rhythms in the way that you function. I think really understanding your strengths and challenges is essential, and examining your environment is absolutely key. And I think also monitoring burnout or chronic depletion is also key for your work as well. I also think for psychologically safe practice for neurodivergent folks in workplaces, I think foster psychological safety, neuroaffirming consultation. I think it's about offering flexibility, appropriate accommodations and adjustments, which are required by law. I need to sort of add in there as well. And also listen to your neurodivergent staff and ask for what they need and if it's reasonable to accommodate in the workplace. I made a little bit of a list of things that really helped me as a neurodivergent clinician, both in practice and at home. So I thought I'd share some things just for ideas in case anyone's looking for something. I was thinking about this at 4 o'clock in the morning. So just hold this in mind. I think really for me, having a solo practice at home and working for myself is a game changer. I also think being at home, there's less of a commute and I'm really able to harness the getting ready at the last minute, and I can get ready in 5 minutes flat. It's a familiar space, and amazingly clients really love it too because it's predictable, reliable. It's got its separate driveway and entrance, and so they, you know, are able to kind of remove that from their executive functioning tasks. I start later every day. I find that I need a lot of time in the morning just to sort of bugger around. I can't tell you what I do with that time, but it's important to me. Between clients, I give myself half-hour breaks between. This is often to accommodate for time blindness, which is often reciprocal with me and the clients. And sometimes I just need to use my mini trampoline brain to kind of look at some other things between sessions. I also find that I really like working across the week. You know, some health professionals or psychologists might sort of say working Monday to Friday is not sustainable, but it is sustainable for me because I do it in smaller chunks in school hours and I have lots of breaks. So I find that sort of helps me. I'm very fortunate to have a very static caseload. So for that novelty piece, I really, you know, really enjoy supervision and teaching. And I sort of get to learn about cases by proxy. So really sort of honing that nosy part of me. I love the analysis of assessment and data collection, but the report writing kills me. So I often outsource assessment where I can, or if I do assessment in practice, I do one every now and again to make sure that I can do it and it doesn't kill me. I am, you know, extroverted and social. You know, how do I get those needs met through solo practice? I have active messaging chats with my close friends and colleagues throughout the day. It's also really essential for me that client work is in my area of passion. I think when I was doing some work with children, I often found that I wanted to work with the parents and support the parents, which often wasn't the way that they were wanting to work or the way that the Medicare model was set up for. So I think also being really deliberate about the presentations that I see. And again, in solo practice, I have got the flexibility and the ability to do that. Thinking about, you know, what makes it work for me personally, you know, around the home, I sort of really upfront want to acknowledge, the privilege of having a dual income household of professionals. So these things might not be accessible for all, but we regularly access a cleaner. Our laundry is outsourced. We use online groceries. They are delivered to our house, so I don't have to go to Coles. We use a meal preparation service for dinner. My husband cooks dinner. I refer to dinner as my husband's portfolio. I sort of manage the children, including flexible schooling for one of my children and appointments for them. We have never done homework. I think for me, the evidence has never really been entirely clear. So at the beginning of each year, I will let the teachers know that homework is too much for us to manage. I do have one child that does love to do homework, so they continue to do that, which is also fine. I think also it's important to acknowledge that I access my own professional supports to stay regulated and medicated. And I think also a shout out to Diet Coke, because that's probably also something that sustains me regularly. So, for other clients and individuals, there can be a lot of shame accepting some of this help, accepting a cleaner or laundry outsourcing. But I really think this is essential to my functioning to do the work that I love, and, a way of navigating life so that I can do these, sort of have these as parts of my family life can make a really big difference to my coping and my functioning. I also make sure that I regularly have school holiday time off and a big break over Christmas, and this is non-negotiable. I book this into my calendar in the year. I think it started when the kids were much smaller and I had to take time off, but I think that's sort of something that's continued to be sustainable for me. So I think probably again for the identified folk, neuroaffirming therapy and supervision are key. And I think this would also stand for individuals who are also wondering about their own neurotype. I think, being able to explore this in the safety of the relationship with someone who might understand or gets it, but also someone that is able to hold your wonderings closely, and, encouragingly in a way that is not going to dismiss you or re-traumatize you. Because no doubt, we also know there's evidence to support this, that if you've figured out your neurotype, the chances are that you're pretty probably right. So I think that's really important to hold in mind too. So this might be relatively activating, discussing and hearing everything that you've heard over this conference, but I think, again, pointing to neuroaffirming therapy and supervision, I think are really important. So I talk fast, so I have finished a little bit earlier, Bronwyn. But thank you for listening, and hopefully there was something that you're able to take away from what I shared today. So thank you very much for listening and for your time and energy.
Sarah, thank you. I think the audience is digesting what you're saying. Thank you for your refreshing honesty in this presentation. I found the studies really interesting and the results very interesting. And it's also curious to me that psychologists haven't been explored within that space.
It's so fascinating.
Yeah. So some comments are coming through. Thank you, audience. Those of you who are live with us now, please do pop something into the chat, especially a question if there's a particular question that you have for Sarah. But what I'm getting is, that was great, Sarah. Thank you for your honesty. Wonderful presentation, Sarah. Thank you for sharing so many recent articles too that I had not seen. And another comment, so much internalized ableism that has its tendrils very deep in our psyche. It takes a bit of unpacking, and I'm guessing, this is a topic that might be quite moving or activating for our audience as well to think about. Maybe there has been some thinking about it or not. So allow us to think a little bit more together, Sarah, just while The audience too might send through a question if there's one. But I'm wondering, can you tell us when we think about neuroaffirming supervision or therapy, I guess we've got some options here, haven't we, that we can suggest? Do you want to speak to that?
I think, you know, holding in mind too that neuroaffirming, because the new standard is coming in as part of the competency, I think we're having to be really, what's the word I'm looking for? Really deliberate about, you know, choosing where we go for therapy and for support. You know, is it someone that genuinely and deeply understands the experiences of a neurodivergent person, or is it something that they've done, you know, only a little small bit of learning around and might not have a full understanding? I think there is the LOPAC, which has got some psychologists that are, you know, they identify as being neurodivergent and are likely, you know, more than capable of offering therapeutic supports to people exploring their neurotype. There's also, particularly for those in the perinatal space, you know, we do have the supervisors that the Perinatal Training Centre or Centre of Perinatal have got available to us, you know, depending on their capacity as well. I think, you know, it might also be exploring supervision or therapy with individuals and seeing if it feels true for you. I think probably like all therapy, regardless of whether it's neurodivergent therapy, is seeing, does this make sense? Does it feel true to my experience? Or does this feel like it's something that's contraindicated to my experience? So it's hard, it's trial and error, but it's a lot of word of mouth as well. You know, who do you see? Where do you go? I think also recognizing that a lot of neurodivergent therapists or psychologists at this point in time are offering a lot of assessment, which is wonderful. But I think sometimes finding therapists with available therapy can sometimes be a bit of a challenge. So again, it's being able to sort of reach out, particularly on the neuroaffirming Facebook page. You know, who's got availability and someone that may be able to support me in this journey. So there are a few spots. I don't know if any come to mind for you, Bron.
Well, I mean, I'll just give a shout out to Sarah Harrower as well, because one of the services that Sarah offers that I really like is if someone is thinking maybe, but I'm not sure that I want to leap right into a full-blown assessment. Sarah offers even a one-off consultation to say, what are the benefits and pros and cons of maybe having an assessment or not. So she offers quite a unique service, I think, that way. I think she's just popped something in the chat, but I'm not sure if it relates to that. Choosing the right person is important. Yeah.
Absolutely.
Yeah.
Yeah.
Thank you for that.
Yeah, it's very important.
And I guess just following on from that a little bit, Sarah, if someone is looking for more resources, if this presentation, your presentation, or the conference generally has initiated some self-reflections, where else can they go to find some resources or just start, because we might just want to explore quietly on our own, not just reach out to someone. So what are some of the resources, and team, feel free to pop things in the chat as well as Sarah's offering her ideas.
I think the resources you shared before the conference, if people get the opportunity to explore some of those, I think, they've sort of been curated. And I think a lot of them from memory are also lived experience podcasts, etc.
Yes.
Which I think, can be helpful for self-identification or helpful to sort of explore parts of, that may resonate with you. I think there is a lot available online in terms of, books and things. I was just seeing if I've got my, one of my books. This is Autism is a wonderful, wonderful book. which has been released recently, and I think it's also a really helpful tool. There's books like Matilda Mosley's The Year I Met My Brain, which is neuroaffirming in the way that it's approached. I also really think that there is a lot of value in social media. I know there's kind of this narrative that, social media is leading to over-identification, but actually I think it's really helping people kind of find themselves. So thanks, Amy. That's the book. That's right. I think it is really valuable, and even part of my therapeutic work is go and hyper focus and spend some time on social media and record or write the things down that really resonate with you. And
Yes.
many times I would end up with probably a couple of A4 pages, because you can trust a hyper focus genuinely, and you usually get a nice report back. So I think that's always a very helpful experience, but we're still developing resources. There's still
Yes.
to learn. I think
Yes.
it's something that we're really trying to establish.
Mm.
Mm.
Thank you. Some things have come through in the chat as well. Michelle Garnett is openly ADHD. A wonderful article by Dr. Josie Barbaro regarding diagnostic rates of autism. Thank you, Sarah.
Yeah.
And just wanted to grab a final comment as I sign you off, Sarah, at this stage. Thank you, Sarah. So interesting. Read the rates of neurodiversity in us. Thanks for sharing personal tips too. Very generous. Yeah. So on that note, thank you very much, and breathe easy. I'll move into some the next bit now, which is, what do we want to do? We want to launch the poll. I think we really want to hear from you, those of you who are with us live. So the poll is going to go ahead and should pop up on your screen shortly. For those of you who are joining us live for the first time, the poll is anonymous. There are 4 questions to answer, and there are 4 options to choose from for each of those 4 questions. So we'll allow a couple of moments just to move into that poll. We're curious to know what you've learned, or how much you think you've learned today. I can see some results coming through. It's great. Thank you. We might just give another 30 seconds just for anyone else who wants to join in. And be sure that you've answered all 4 questions. I can see it's, oh yeah, good. It's coming through. And just the last 10 seconds before we close off that poll. Final opportunity. Thank you for participating. Of course, data is important to us. And we might end that poll now. Thank you so much for participating. And we'll share the results with you. So that should flash up on your screen. Yeah. And it looks like, well, some of this was known to you, the content from both presentations. There was quite a bit that was new, so that's helpful, right? We're glad to hear that. Thank you for participating. Here comes now your reflective prompt. This will show up in the chat box. And this is to help you consolidate your learning and to make a commitment to at least one thing that you are taking with you from the presentations today. It also gives us some feedback and data. Your comments aren't anonymous, but we wouldn't share your name if we share any comments. I'm just allowing some quiet moments for responses. Just allowing a couple of moments now for the responses to come through in the chat. I think the book is called Is This Autism? Rather than This is Autism, to answer a direct question in the chat. How important it is to widen our lens. How important it is to widen our lens. Yeah. Looking for the intention in the dyad interactions and widening the lens. Love that. I loved from the place of affirmation, we can scaffold and support. Beautiful. Yeah, from the place of affirmation, we can scaffold and support. I really liked the idea of looking for the rhythm rather than the routine in the mother-infant dyad. Yeah, I like that too. Looking for the rhythm rather than the routine. Routine might feel too rigid or constrictive. Assumption of universality is saturated in the early years space. Things are changing slowly. Be a champion. Love it. Creating a sensory safe space and play between parent and child. Yeah. Thinking outside the norm in parent-infant dyads. Beautiful. Connection does not need to be neurotypical to be true. It needs to be felt, safe, responsive, and real. Love it. Thank you for these comments coming through. I'll allow you to keep chatting in there and add what feels important to you, and we appreciate you doing that. Today concludes the content portion of our conference program. We will have a 5-week break now and then reconvene for our special bonus Q&A session with the speakers. So this break allows you time to take in, to consider, to digest the many ideas shared over the past 3 days, to go back and rewatch all or portions of the recording. It might also allow you time to start playing with some changes that you want to implement in your work. We would love to receive questions from you in the next few weeks. Because we only have one precious hour together with the panel, we will endeavour to have a range of questions where we can hear from all of the speakers. After the session today, and possibly early next week, you'll receive a follow-up email, and within that email, there will be a link to a document where you can add your questions. So it'll be themed under the 4 sessions that we've had, and you can add in your question that you would like to be answered by the panel. A reminder to connect with us. A reminder to connect with us on our conference website under conference speakers. We are all listed in this frame, in this image. There's just the top 3 of us there, but all of the speakers are there. And I wanted to let you know that you can connect with us down here, so you can read more about us. And if you open up that little part there into a different page, there's the ability to contact us. So you can contact any of the speakers and connect with them personally. There are also all of our websites and socials listed, so you can follow each of the speakers on the socials. We love to stay connected. And of course, pulling together a conference is not a solo effort. It requires cooperation from a team of individuals and organisations. I'm terribly grateful to our contributors, our speakers, and their organisations who provide their time and expertise. I also acknowledge our supporters, organisations who have helped support the coming together of this conference. Thank you, LOPAC and CAPIA, and both organisations also have their own upcoming conferences, so do check those out if they're of interest to you. Be sure to spend a little bit of time in our partner directory in our virtual exhibition space, where you can learn more about the contributing and supporting organisations. And of course, a special thanks to Nikki Abercrombie, Event Manager Extraordinaire. Nikki, you always go the extra mile, and it's always a pleasure to work with you. Thank you for your heartfelt support in this space for a number of years now, actually, when I kept emailing you last year, the year before, Nikki, I think I'm going to do this conference. Are you available? Yes, I'm available. Anyway, it's taken until now, Nikki, but we've done it. So yay. And to the team at Fordtronic, thanks, Jono and Dave, for having our backs with the tech, that's for sure. Thank you very much. And with gratitude and acknowledgement to my board of advisors for this conference, Sarah Edwards, Amy Pember, Sarah Harrower, thank you for having my back and for providing guidance, support, encouragement, and advice in the drafting and curating of this conference program. Superstars, all of you. And Sarah, thank you for your heartfelt acknowledgement before. I appreciate that. All right, in closing this portion of the conference, as I pause on this final slide and make my closing remarks, I invite you, those of you who are with us live, to make your closing remarks in the chat box. Please let us know your overall or favourite part of this conference if you haven't added that in yet. In closing this portion of the conference, I am extending my gratitude to all of you for supporting this event and for co-constructing a safe learning space to explore the important issues in supporting autistic and ADHD folk in the perinatal period. I do hope this has been a valuable and enriching event for you. We know we haven't covered everything, and we know there's still a ways to go. But what an incredible start we've made in these last few days. We look forward to seeing you on the 28th of June for a final precious hour together. In the meantime, stay connected. It's good to keep the conversations going. Please connect with us, all of the speakers, and beautiful comments coming through in the chat now. Thank you so much. I noticed that someone had said earlier, actually while you were speaking, Sarah, I'll see if I can find the comment because it was so nice, and it's a beautiful way to end. Allow me to see if I can find it. Oh, so many comments. I'm having to scroll. Such a warmth here at this conference. I'm appreciating the realness. Oh, I've lost it because people keep commenting. Oh dear. Thank you for bearing with me. appreciating the realness and respect demonstrated at this conference. Yeah, thank you very much. I'm going to close out there. For those of you who are live, please do head into the virtual meeting space if you would like to. I'm not sure that our speakers will be there. They're very tired after giving their presentations at this time. But remember, you'll get to see us all again in 5 weeks' time. For now, thank you very much and farewell. Bye-bye.